We ready to go? If somebody can give me a
We can hear you, Doctor.
excellent, Aiden. Thank you very much.
Of course, of course.
I'm going to shift now to slide 58. Here we go. And we'll ask a couple of questions to reinforce treatment plan and evaluation ideas. 58, I said, yeah. Okay. Just to reinforce the last hour before the midday break. Question 17, asking details about a patient's past mental health treatment helps to clarify whether specific psychotherapeutic and/or medication treatments were effective. This is an important part of the initial evaluation because it informs a treatment plan, a current treatment plan, true or false. Oh dear, I gave it away. The answer, shoot. The answer is that it's true. What worked in the past is what's going to work in the future. And however, the caveat of don't be so sure when they say this didn't work in the past because it might well have been an inadequate trial of medication. So you have to probe a little bit more. Question 18 nails it. What are the important aspects of the psychosocial history to ask about as part of a thorough initial evaluation? Is it family, peers, school, home environment? Is it trauma, deaths, attachment disruptions? Is it media and internet exposure? Is it access to firearms? Is it all of the above? And the answer is, of course, it's all of the above. These are all important aspects of a child and adolescent psychosocial history and their current living situation. Now we're going to jump into the actual disorders, the different diagnoses and the medications that are often used for them. I don't believe I have, but I hope I haven't scared anybody away from the morning or the first session, where I kind of lay a lot of crepe and offer and suggest caution and thoroughness and looking at all stakeholders. And this is both fraught with tension and a little bit of worry to do everything right and document it well. But I want to leave you, I hope, with a sense of optimism, hopefulness, and these medications, for the most part, can be extremely helpful for children and adolescents with particular behavioral presentations, symptom presentations, right? Not exact diagnoses. And I have seen incredible turnarounds of kids and adolescents where maybe medication wasn't the be-all and end-all, although it was for a number of kids, especially hyperactive kids, but it made a significant difference and was worth and certainly paid off in terms of the benefit versus risk analysis. So I hope I'm not scaring anybody away, but I hope I've given enough perspective and thoughtfulness about this whole process that you are well grounded and have thought about a number of these issues, including the political climate and cultural aspects. Okay, the so-called internalizing disorders, and that's just an arbitrary differentiation between different diagnoses that's used for children and adolescents of the ones that affect the inner life of the child, if you will, perhaps more than the external environment, versus the externalized disorders that have more impact on the environment and perhaps less impact on the individual. kid. So we're going to go through, and actually, and quite frankly, the first part of this course, the first quarter, is to me the most challenging part to offer that balanced approach, rationale for treatment of use of psychotropics for kids. This rest of the course, including internalizing disorders, externalizing disorders, the other disorders, etc., newer medications, etc., is a bit of memorization and a bit of repetition. But I hope I'm going to leave you with the thought that, hey, we're treating symptoms here, and of course, if this patient diagnosed with eating disorders presents with some depressive and anxiety symptoms, as well as OCD type symptoms focused on eating as the obsession, and perhaps not eating or regulating their eating as a compulsion, you treat the symptoms. So you're going to see a lot of repetition of medications, and I think that's good because it'll reinforce stuff. We're going to start out with the depressive disorders. Straight out of DSM-5, but do remember that childhood depression is different in its presentation than adult depression, and this is adult criteria, right? So kids tend to show less guilt and worthlessness. They may show more agitation. They may show as much sleep problems. They may or may not show or exhibit thoughts of death. But the one thing that grabbed me about this is that kids tend to not show as much guilt or worthlessness. And of course, the criteria have to be met for longer than 2 weeks. All right, so what have we got here? Medications for depressed mood. The drugs of choice these days are the SSRIs, the selective serotonin reuptake inhibitors. Here are the common ones prescribed, even the newer ones that are being prescribed, which are down on the bottom, Viibryd and Brintellix. They're all SSRIs, and I don't know if you want to compare directly to adult doses, but these are quite similar to adult doses. Maybe the difference is that the lower doses are included. That fits a philosophy that I think is important to follow with children and adolescents, is to start slow and use lower doses to start with. You may find that 5 milligrams of Prozac is going to be effective for that kid, but if you jump at 10 milligrams or even 20 milligrams, a pretty typical adult dose, that you might be overshooting the mark and it's unnecessary, and you may give the kid more side effects. I also caution you about trying for a minimum of 2 to 6 sessions of psychotherapy and family therapy prior to medications. What if you can, with a behavior plan and working with the family, some behavior mod techniques, reward extinguishment, etc., improve the kids' behaviors so that they are not as depressed, so they're more connected to their family, so that they're being heard more, that their sleep-wake cycle is being taken into account with some, maybe the TV has to be off, maybe the cell phones and the social media stuff has to be stopped at 9 p.m. or 10 p.m. These are simple behavioral interventions that should be talked about and considered before resorting to medication. So that's my rule of thumb: 2 to 6 psychotherapy, family therapy sessions before medication treatment. More often than not, that's not realistic. It isn't going to happen. you can't get a therapist. You can't get a family therapist. And there will be this leap to medications. I get it. And if I'm looking at the whole system, if you will, that's better than nothing. So compromise and be willing to be flexible. I've certainly learned more of that as I've gotten more experience of not be so rigid, of my way or the highway. Why are the doses similar to adults? Well, think about kids and their eating. I don't know about you, but the restaurants that had all you can eat, and we'd go at 5 p.m. for and this is age 16, for the first meal at 5 p.m. and then lollygag about and have the second meal at 8 p.m. and walk out of there feeling like it's, Thanksgiving dinner or something, and you're groaning. You can't do that as an adult, right? That's just not what we do as adults. And around age 30, things go really downhill in terms of metabolism, and we can't eat the way we did when we were teenagers. So the metabolism is robust for children and adolescents, and that's why adult doses tend to be used with adolescents. Let's start at that low dose. Let's talk about bupropion, Wellbutrin a bit. This affects the reuptake of serotonin, norepinephrine, and dopamine, the third important neurotransmitter. It's also used for smoking cessation, and it's called Zyban. I just remember feeling totally conned by a drug rep who came in to talk with me about Zyban, and I said to him sort of innocently, but also a little peeved, aren't we talking about Wellbutrin, bupropion? He said, yeah, different name. Well, it'd be nice to have you start out by saying, let's talk about bupropion, but nevertheless, I'll listen to your spiel about Zyban and quitting smoking. It's also used for seasonal affective disorder, causes less sexual dysfunction than the SSRIs in general, and teenagers tend to appreciate that. And it's a good reason not to take medications for teenagers, is that it dampens down their libido. Bupropion causes less sexual dysfunction. And another cool thing, particularly for teenagers with bupropion, Wellbutrin, is that it about 25% of patients experience some initial weight loss on it, and it's considered sort of weight regularizing. If you're underweight, you gain a little. If you're overweight, you lose a little. And that tends to be better than the SSRIs, which can have you gain weight. But side effects can include restlessness, agitation, sleeplessness, headache, rashes, stomach problems, and in rare cases, menstrual irregularities, hallucination, even bizarre thinking. High doses can be toxic and may cause dangerous heart arrhythmias. Seizures have also been reported, usually in patients with eating disorders, anorexia or bulimia, or who have other risk factors for seizures. And that is that their electrolytes can get out of whack with their bulimia or eating disorders, such that they're hypovolemic, they have inadequate fluid intake, and that can also be a setup for a seizure. Now, when Wellbutrin first came out, we were warned that it had 4 times the risk of seizures as other antidepressants. It has since been found, not too long after it came out, within the first 5 years ago, that was an overcall, and it probably isn't 4 times higher. It may be slightly higher a risk of seizures than the SSRIs, but not 4 times. So we're not overly concerned about that. But think about that. Anybody who's had a head injury, anybody who's had an undiagnosed seizure disorder, it could potentiate a seizure. It won't cause a seizure, but it could help increase seizure activity in one who's already prone to seizures. That's the way I think about it anyway. All right. I won't go into the doses too much, but just know that they're start low and you can go up to adult doses. Okay, question 19. So psychotropic medication dosing for children and adolescents is similar to adults due to robust metabolism. Analogy is eating. With emphasis on starting at a low dose. See, I give away my questions before I even ask them, especially these throwaway questions. That is obviously true. Okay. Now, let's head into other medications used for depression. You've gone through the SSRIs. You've maybe maxed out the dose. You've tried another SSRI as an alternative. You may have tried Wellbutrin, and you're not getting the full robust response. There have been uniformly good studies to show that the antidepressant response for depression with antidepressant medications is approximately 70%, 70. So you've got 30% that don't respond to medication, at least the first trial, etc. So you would be wise to escalate the situation and start using a dual action antidepressant such as Remeron, mirtazapine, Effexor, Cymbalta, Prestique, and the newer one, Fetsima. Again, lower doses to start, but pretty average adult doses in the end. Now, you could go back to the old-fashioned tricyclic and tetracyclic antidepressants. Why on earth would you do that? Well, here's a good rationale for it. If it worked in the past, if it worked for a family member who was a child back then, these Elavils and Tofranils were developed in the 1950s and 60s, Norepinephrine in the 60s, and I used to prescribe quite a bit of it before the SSRIs. I don't like to prescribe them because they are quite toxic in overdose. It is easy to get heart block and death with an overdose of Tofranil or Elavil. They were notorious for causing overdose death if you took like your month's supply that you just got from the pharmacy. So, and that just doesn't happen with the SSRIs or Wellbutrin or the dual action antidepressants. Perhaps you have a young child who has, by the way, bedwetting, and is an irritable, depressive little kid. It might be helpful for a low dose like 50 milligrams of amitriptyline or 10 milligrams of nortriptyline, Pamelor. It also seems to help kids who have comorbid ADHD symptoms. Now, I'm kind of giving you the academic picture because I really don't prescribe. I haven't prescribed these for years, but they're there and they're available. Interestingly, surgeons prescribe Elavil after surgery to help with two things. It really is great for insomnia, and it also seems to treat what is increasingly recognized as, instead of a post-traumatic stress syndrome after surgery, but a post-surgery stress syndrome. If you go through a major surgery, or you happen to be a kid who hasn't much resilience and is frightened and in this scary hospital and mom and dad aren't there, around the clock and et cetera, can be a pretty traumatizing experience to be in a post-surgery situation. And Elavil, Tofranil can be quite helpful, and they're used by the surgeons. Surgeons are kind of old-fashioned, and they're very new-fashioned in their techniques, surgical techniques, but in their use of psychotropic medication, they're pretty old-fashioned. And that's not a bad thing to help with that insomnia and that traumatic stress following surgery. Okay, but it is interesting to note that the only people these days that are prescribing tricyclics are the surgeons after surgery. Nifazodone, Surzone. This was a newer medication that was touted as having the benefit of the tricyclics, tetracyclics, but without the toxicity, if you will.
A question?
Yes, please.
Forgive me, I might have missed it when you said, so it says dual action. Is that serotonin and norepinephrine? Is that the
Exactly
two?
right.
Okay.
That's the dual action aspect.
Thank you.
Yes. Okay, I want to, just to throw a little bit of water on this fire, I want to throw out a couple of controlled clinical trials with children and SSRIs. Insufficient evidence to support a child indication with, I got to go back a slide. Well, I have to go back 2 slides. Here we go. With citalopram, Celexa, this study says it doesn't work with children. Sertraline, Zoloft, pediatric studies, 2 placebo-controlled clinical trials, insufficient evidence that it's a benefit. Paroxetine, Paxil, insufficient evidence in a couple of controlled studies with children. Venlafaxine, that's a dual action. Venlafaxine Effexor, insufficient evidence that it benefits pediatric patients. And weight loss was significantly higher than the treatment group. Also, it seemed to affect their growth in terms of height. So if you go back to the research, the hard research, the double-blind placebo-controlled studies, you'll be really kind of disappointed. And yet, anecdotally, and in my experience, they work with a significant percentage of kids. So go figure. So here we go. Clinical trials with SSRIs, citalopram, paroxetine, sertraline, as well as dual-action antidepressant venlafaxine, do not support their use in the treatment of major depressive disorder. Hey, you know what? Maybe they don't have major depressive disorder. Maybe they have depressive symptoms that you're treating and are benefiting from a lifting of those depressive symptoms. Because after all, remember, the study was for major depressive disorder. Maybe they had dysthymia, or they were on a spectrum, if you will, where they had low-level symptoms of depression, etc. So here's another question, 21. Some studies of SSRIs prescribed to children and adolescents showed an increase in the incidence of suicidal thoughts, mood fluctuations, hostility, tremor, sweating, hyperkinesia, decreased appetite, agitation when compared to placebo. True or false? Well, the answer is it's true. So you have to be careful about this. Monitor closely, watch for untoward, unexpected symptoms popping up, etc. Okay, now let's look at some of the side effects for some of these medications, the SSRIs, the dual action, the tricyclics, the tetracyclic antidepressants, and noradrenergic antidepressants. You may have cognitive blunting, word finding problems. There's a classic Prozac story, SSRI story, of it's on the tip of my tongue, that word. What was that word? Word finding problems. Racing thoughts. Did that agitate the kid, or are you unmasking a juvenile bipolar disorder? It's a question. So we talked about cognitive blunting. We talked about, we have to talk a little bit about psychiatric, what if that kid with the SSRI started becoming agitated, started becoming anxious, perhaps even started hallucinating, got paranoid. Well, there's more to the picture. It doesn't appear to be a depressive disorder. It appears to be more of a mood disorder, perhaps. Even a perhaps combined mood and psychotic disorder. Perhaps it's an emerging schizoaffective disorder. And the antidepressants can actually help in a funny way to expose the true nature of the depressive presentation symptoms. So you can use the side effect profile with that kid to help figure out what's going on. Very helpful. By the way, in the old days, especially with the tricyclics and the antipsychotics, how did you know when you had the kid at the proper dosage? You had them on such a high dosage that it snowed them, and then you'd back off a little bit. They had such high side effects, and then you'd back off a little bit. It sounds cruel, and it was cruel, admittedly, but it was the way we were taught to how do you get the kid on the right dosage? You jack them up too high, and then you back off. It's not the way I like to do things, and I stopped doing it the way I was taught very quickly on. I'd rather go slow and low and not put them through that. Takes longer, have to be more thoughtful, etc. But hey, is that such a bad thing? Neurological, seizures. You're juicing up the central nervous system. You're activating the brain. And if that kid has a pre-existing seizure disorder or occult underlying subclinical seizure disorder, you could unmask that, and then someone could accuse you of you caused a seizure disorder. No, you didn't. You just unmasked a pre-existing seizure disorder. Cardiovascular, you can have arrhythmias, you can have conduction delays. The way to kill yourself with a tricyclic antidepressant is with heart block. You conduction delay. That's what kills you with a tricyclic like tofranil. They have a cardiovascular death. All right, gastrointestinal, nausea, constipation, diarrhea, could be one or the other. Sexual functioning dampened down, endocrine functioning, hypothyroidism, diabetes. It's considered category C. That's the old categories in the old parlance. And what that means is that it can cause birth defects in animals, but not, frankly, in humans. But hey, if the young woman, if the older adolescent female is taking an antidepressant medicine, they should be cautioned about pregnancy and protection and all like that. Don't take a chance. All right. And so we talked a little bit about, and just a plain old allergic reaction that can happen with any medication, whether it's a blood pressure medicine or an antidepressant or a heart medication. Otherwise a antibiotic, you can have an allergic skin reaction, hives, etc. Can happen to anything. This is the so-called black box warning, slide 73, that is in the physicians, or they now call it something else, PDR, provider's desk reference, I think, which is a better way to say it in today's day. And so this is the scary black box that talks about the possibility of suicide and antidepressants. So it's pretty generic, and you should be cautious because of it. This is the one for Cymbalta, but it's for all the SSRIs, actually. Okay, now we're heading to the bipolar disorders, the mood disorders, where this is straight out of DSM, elevated, expansive, irritable mood, 3 out of the 4. Tends to be different with kids and adolescents and adults. Kids tend not to have the grandiosity as much as maybe an adult with a frank manic disorder, but they certainly can have the insomnia, the pressured speech, the racing thoughts, distractibility, the psychomotor agitation, and the poor judgment, right? So, and this needs to be at least, you need 3 or 4 of the following symptoms for at least 1 week. Let's talk about juvenile bipolar disorder. This is the great masquerader. It mimics fairly normal behavior in children and adolescents, but at the extreme. It has me hesitate a little bit because this is when I bring up my example in my family of my older brother Bob, who had his first psychotic break at age 12 when I was 10 years old. And he spent the next 40 years in and out of psychiatric hospitals and jails with about, out of those 40 years, about 10 or 15 years of stability intermixed in those 40 years. Given that he was had his first psychotic break in the early 1960s, by kind of classic definition, he was psychotic. That means he had a diagnosis of schizophrenia. That's how crude we were back then. Any child that was psychotic was given a diagnosis of childhood schizophrenia. Well, it turns out they weren't too far from the truth with Brother Bob, because his bipolar disorder, which was classic juvenile bipolar with the mania, pressured speech, wouldn't sleep for a week. He was reading books in the middle of the night at age 13 and stuff. He was very bright, very charismatic, and a really good guy at heart. Totally ravaged by his mental illness, however. Racing thoughts, distractible, incredibly poor judgment. Just telling someone the other week about one of my memories of my brother when I must have been 14 and he was 16, and he was decided in a manic episode that he needed to run away from home in the middle of the night, and taking a steamer trunk with him, which is pretty typical bipolar behavior, through the bedroom window, making the most crashing earthquake-like noises in the middle of the night. The only ones home at the time were my mother and myself, and my mom, being a typical mom, tried to save him from himself, tried to save him from running away, tried to stop him, and he was so psychotic and so out of control that he started beating up on my mom, and that just clicked in my head, and I attacked him to protect my mother. And I was just lucky enough to grab the porch 4x4 post with one in one elbow and his neck in the other elbow. And he was superhuman in strength and bigger than I was and much more muscular than I was. But because I had leverage with that 4x4 post, I could stop the action and basically start strangling him if he kept moving. And I just whispered to him, stop moving, and I'll let off some pressure and let you breathe. And he wouldn't do it, and I'd strangle him, and he would start, passing out, and I'd let off pressure. It was a very deliberate, and I was, all the adults around after that said, my God, this kid Tom has this amazing ability, brings up emotions right now, all those years later. And I'm sure that had something to do with my becoming a psychiatrist, because in my odd ex-British family, there was always a doctor and a priest in every generation, and Bob announced that he was going to be the doctor early on, like at 6 or 8 years old. And I kind of said, great, I'm off the hook. And then he crashed and burned, and I had to do it. I have no regrets. I saw my brother Bob and every one of my patients, and I tried to treat them with the love I had for my brother, also the boundaries that I learned from my brother. And he was a dear guy underneath all that craziness. By the way, the end of that story was that Bob whispered to me, if you let me go, I won't hurt you or Mom, and I'll run away. And I said, let's give it a few minutes till I can trust you. And I did. We gave it about 5 minutes with both of us breathing like bulls in the middle of the night. And I let him go, and he ran away. And we called the police, and they picked him up a few blocks away and hospitalized him. There was one clue that my brother Bob had that I think is part of juvenile bipolar that I've never read anywhere, and that is he never learned from any of his antics or his acting out or his mistakes. It was like it was Groundhog Day every day all over again. And to me, that's part of mental illness, is a fundamental denial, especially with bipolar, that there's really anything wrong with you and you don't really have to do anything or take responsibility for that. I don't know. It's just a supposition on my part. Okay, sorry about that. I didn't think this stuff affected me quite the way it does. So how is a backdoor diagnosis of bipolar disorder made? This is question 22. Do you elicit the family history going back several generations? Bipolar disorder, to me, is one of the more heritable genetically based disorders. It certainly was in my family with a halfway bipolar sister, a full-blown mood disorder psychotic aunt, and other cousins that are exhibiting mood disorders. Or is it B, an antidepressant medication trial unmasks manic symptoms in a patient who had no prior manic symptoms or episodes? Or is it C, you instruct the parents of a depressed child or adolescent to slam the back door? And if the patient is sufficiently startled or greatly startled, he probably, typo, has bipolar disorder. Well, that's sort of a silly one. The answer is B. A backdoor diagnosis of bipolar disorder is made when you unmask manic symptoms in a child or adolescent or adult, where you give them an antidepressant medication and they start exhibiting manic symptoms. It's not that you made them manic or you created the mania, you unmasked it. You precipitated a manic episode in someone who perhaps has not exhibited a manic episode as yet. Many children and adolescents not the majority by any means, but many children and adolescents who you treat for depression actually have bipolar disorder, and they're simply in a depressed phase. Well, it's really obvious when they go into a manic phase, but the depressed phase looks just like depression. However, I have to say that the depression of bipolar disorder is different than unipolar or major depression. And I learned this from Brother Bob, but I've seen it in other patients with bipolar disorder. When they're depressed, it's like they are the walking dead. When my brother got depressed as an adult, he would lie on the living room couch for 2 weeks at a time. He did not have the energy or strength or mental capacity to even go up to the bathroom. He peed in a jar next to the couch. He would lose 20 pounds in 2 weeks because he just wouldn't eat. He would become emaciated, and he would also be very foggy and slow in his thinking, as though he was stupid or demented. That's bipolar depression, in my opinion, and I've seen it with other patients in varying degrees or intensities, where you don't see that in unipolar depression. You don't see that depth of falling down, if you will, or degeneration. And it kind of makes sense if you think about it, or it makes sense to me anyway. The mania is like a brain on fire. The depression that either is before or after the mania is the opposite, the deadness, the lack of any fire, the dead. Pretty interesting. All right. How are we doing? Okay. So let's talk about pharmacologic treatment for bipolar disorders. The mood stabilizers, lithium was a classic, came out in 1970. If you know the old story, developed by an Australian cardiologist that was a salt substitute, because lithium is a salt on the same periodic family chemical table as sodium. So the cardiologist was using it as a salt substitute. And two things happened. One, I shouldn't laugh, is that he was killing off his patients left and right with lithium toxicity that wasn't known about at the time. And then he had some bipolar patients that had heart disease, and he put them on lithium, and they like dramatic improvement, dramatic turnaround. It was like night and day. It looked magical, and they were off and running. Why 1970? I know that for a fact because my brother turned 18 years old in 1970. He was one of the first patients to be tried on lithium, and he had a remarkable magical turnaround. He became normal at age 18, and he was normal for the next 10 years. He married, had a child, worked a good paying job. He loved animals, and he and his wife had horses and goats and ducks and chickens, and it was this idyllic, wonderful marriage until he started getting toxicity to lithium, a hand tremor that never got better and actually was so bad in his 50s that he had trouble eating, holding a utensil. And that was residual from lithium from years back. And also it was poisoning his kidneys, and his BUN and creatinine were rising, and he couldn't take it anymore. So they took him off that, and he was then placed on every other medication you could think of for psychosis and mood disorders, Tegretol, all the mood stabilizers, and all the antipsychotics, and he ended up with only partial response and near homelessness in his 30s. Of course, he got divorced, and his poor son, who, when he suicided, his poor son was 19 years old and wouldn't come to the funeral. And he's a good guy, and he's in his mid-30s now, and I'm in fairly close contact with him 4 times a year or so. And he's doing pretty good with his mood disorders, but not nearly as serious as his dad's, my brother's. So lithium was the golden medication at the time, and since there are other ones that may not be as effective, or it may be as effective, these are all the anti-seizure medications, mood stabilizers, and there's some sense in using an anti-seizure medication for bipolar disorder. You can sort of vaguely imagine that you want to calm down that fevered mind with bipolar, and you use an anti-seizure medication. And for the most part, they can be extremely helpful. You may have to add an antipsychotic to it, and antipsychotics are increasingly being used as monotherapy. Forget the anti-seizure meds and all the potential trouble with anti-seizure meds that we'll go into a bit. And here are the doses that are pretty standard adult doses with the lower dose at the beginning to start low and slow. Okay, so atypical antipsychotics may be prescribed. See, I give away my questions before I even ask them. Atypical antipsychotics may be appropriately prescribed as monotherapy for bipolar. That's true, especially with the advent of the atypical antipsychotics that tend to have fewer side effects than the older ones like Haldol and Thorazine and Millaril that were pretty messy in terms of side effects. So let's get into some of these medications in a little bit of detail. Lithium, the side effects. Increased urination, increased thirst, metallic taste in your mouth, right? It's a metal. Tremor. This hand tremor, I'm mimicking it. You can't see it, but it's like out of control. It's like Parkinson's tremor. Ataxia, unsteady gait, weakness, vision changes, drowsiness, nausea, vomiting, diarrhea. It can really affect your GI system. Cardiac arrhythmias, EKG changes. It can make you hypothyroid, permanently hypothyroid. It can sort of poison your thyroid gland, and then you have to be on Synthroid or replacement the rest of your life. It can cause seizures or coma. It can cause increased cerebral spinal fluid pressure. It can cause paralysis. The original blood level that they recommended was between 0.5 and 1.5. Well, they lowered it down and tightened it up, saying that you really don't get a therapeutic dose or level at less than 0.8 milliequivalents per liter. And you can get toxicity at doses over 1.2 milliequivalents per liter. And I have a case example for you indirectly. I was working as a medical director for an insurance company and had to review this case where the doctor had settled for $50,000 in a medical malpractice suit. And I had to check him out and make sure he was an upstanding guy and, should be kept on our insurance panel. I talked over the case with him, and he was kind of scratching his head over the phone with me saying it was the damnedest thing. It was a 17-year-old female who he had put on lithium for bipolar disorder. She started getting flaky coming to outpatient sessions. She refused or just plain neglected to get serum lithium levels despite the doctor's requests, and he kept seeing her and kept prescribing it anyway. And she ended up with permanent kidney failure, resulting in dialysis for life 3 times a week, starting at age 17, and he was sued for medical malpractice. He should have been sued. You should not prescribe lithium to someone who doesn't get blood levels on a regular basis, and we're talking about once a week for the first month, once every 2 weeks for the next 2 or 3 months, and then once a month for about up to the next 6 months, and then if all is going well, about 4 times a year, quarterly, after that. And she had gone for like 8 months without a lithium level. And I had another patient, or not mine, but one that was paralyzed from the waist down from lithium toxicity. I think hers was a lithium overdose in a suicide attempt of an adult that I did weekend call on once in the hospital. So this is pretty toxic stuff. You have to monitor kidney functions regularly. It can be quite toxic. Okay. So lithium toxicity, here I am, I'm giving away all my questions. Lithium toxicity can occur with serum lithium levels only slightly above the therapeutic range of 0.8 to 1.2. And indeed, it could be 1.3, 1.4. And in the old days, we would jack people up to up to 1.5. We were cowboys. Okay. All right. Let's take a break, a 10-minute break, and then we're going to talk about Depakote, the anti-seizure medication, and move through the rest of the anti-seizure medications this afternoon. So I'll meet up with you again at 3 minutes after the top of the hour. Thank you. Let's get back into it. Hey, before we move on from lithium, I want to mention something. This is more relevant to adult patients, but I think it's a nice little pearl that you may not be aware of. So we have autism spectrum disorder, right? Well, if you want to put it in a similar context, we also have bipolar spectrum disorder. We have schizophrenia spectrum disorder. We have anxiety spectrum disorders. In other words, people range from mild to moderate to severe symptoms in their life course with these prominent symptoms of psychosis, anxiety, mood disruption, attention deficit, etc. There's even a lightweight ADHD and heavyweight ADHD. So with respect to bipolar disorder, and if you think of some adults, they actually use their bipolar disorder to advance their lives, their careers, etc. There's a particular woman who I invited to a conference to do a presentation about her work that's public and out with bipolar disorder. And her name is Ayelet Waldman, W-A-L-D-M-A-N. Ayelet is A-Y-A-L-E-T, if I'm not mistaken. She lives in Berkeley with her Pulitzer Prize winning husband, Michael Chabon. And she has bipolar disorder. She's written on this. She's written a book on it. And she has a very special relationship with her prescribing psychiatrist where they have a deal that she has a low level of hypomania at all times. That is, when she's cycling into mania, such that she can be very productive in her literary career, that she can be available and be the super mom that she wants to be with their 5 children, with 2 hardworking literary parents and a very active schedule and soccer mom and all that stuff. And I, in my private practice, have helped many an adult manage their bipolar disorder so that they are just on the edge of hypomania and use it productively in their lives. They need to get balance, and they need to have balance in their lives. They need to get decent sleep and not be so manic or hypomanic that they cycle out of control and need to be hospitalized. And I've had many an adult patient trained, so to speak, by me to recognize the emerging symptoms of mania and hypomania. For one fellow I remember in his mid-30s, he had a standard 8 hours a night of sleep. When he went down to 6 hours a night of sleep for more than 2 or 3 nights, that indicated he was heading into a hypomanic episode. We dosed up with sleeping pills and atypical antipsychotics, and he rode it out without any problems in terms of his work and his concentration and all like that. So that's a very helpful way to use lithium and other mood stabilizers with people that take control of their illness and manage it, allow you to help them manage it to their advantage. Hope that makes sense. All right, Depakote valproic. This is an anti-seizure medication that is very helpful for mood disorders. It's probably the most common one after commonly prescribed medication for mood disorders, that is mania, other than perhaps Tegretol. But look at the common potential side effects. This is what I wanted to grab you with, of the weight gain. Ooh, I have a typo. It's weight loss. Usually it's weight gain, and usually an increased appetite. Hair loss, rash, sensory changes, ataxia, dizziness, nausea, vomiting, constipation, vision changes, emotional lability, even psychosis and blackout, and a flu-like syndrome. These are common side effects, so they all have to be watched very closely. So what serious side effects might a patient experience with Depakote? Would they have low platelet count? Would they have kidney failure? Would they have liver failure? Would they have coma? Well, it's a little bit of a trick question, not really. But when you hear kidney failure, think lithium. Don't think anything else. It's liver failure for Depakote and most other medications if it's toxic, and also low platelet count. So that answer is A and C only. All right. Serious side effects from Depakote: hepatic failure, pancreatitis, the low platelet count, and anemia. And this is the typical serum level of 50 to 150 micrograms per mil for Depakote. Now, here's the next one: Neurontin, gabapentin. Actually, Tegretol should be the next one, but I throw in Neurontin because, frankly, Neurontin has been overhyped in the last 20 years as the cure-all and be-all and end-all for anxiety disorders, mood disorders, etc., and it's a crock. The pharmaceutical company's been dinged for overselling with their drug reps, and it's as a cure-all. I remember very well my failures in my prescribing, and one of them was with Neurontin. I had tried pretty much every medication under the sun over a number of years with a patient, I call her my second best teacher, who had schizoaffective disorder and borderline personality disorder. Very tough patient to treat, multiple hospitalizations. And every medication we tried backfired because she was so exquisitely sensitive to side effects and also just psychic changes with her borderline personality disorder that it's like her body or her mind sabotaged every medication. And wouldn't you know, I had her on Neurontin. She got up in the middle of the night to go to the bathroom. She fell and broke her pelvis because she had an ataxic gait and she was sleepy and fatigued. And I feel really bad about that. It made me even dislike prescribing Neurontin. I disliked the drug reps overhyping it, and I never really used it after that. And I haven't heard any really good things about it, but it's considered lightweight and kind of trendy, and it doesn't cause weight gain and all that. But I don't think it works. I think it's more side effect than benefit. You can get seizures and Stevens-Johnson syndrome, which we'll talk about with Lamictal more. Okay, Tegretol, probably the second most commonly prescribed anti-seizure medication for bipolar disorder. One of the, I think I mentioned to you earlier that the juvenile hall medical director said half of the boys in the Sacramento Juvenile Hall were taking Tegretol for violent behavior. Okay. Vision changes, clumsiness, confusion, high or low blood pressure, GI symptoms, rash, photosensitivity. It's actually pretty well tolerated despite these so-called common side effects because you go slow and you go low. And every time you change doses, it increases the risk of side effects. So you try to stretch it out. Use a lot of talking therapy in the meantime, and a lot of life skill help to help them through a tough time. Serious side effects. These are all anti-seizure medications. They have serious potential problems: kidney damage, kidney failure, anemias, arrhythmias, heart block, hepatitis, again, Stevens-Johnson syndrome. Topamax, topiramate, its claim to fame is that it tends not to cause increased weight. And so, but other people say that it doesn't seem to be as robust or as strong in its effects. I have mixed feelings. I've seen it work on some patients and not work in others. But they don't gain weight. So sensory changes, fatigue, dizziness, ataxia, concentration problems, agitation, retardation, nausea, speech and language problems. These are all anti-seizure medications that really affect the central nervous system. So you gotta be really careful, right? Okay, Lamictal. This is the biggie for Stevens-Johnson syndrome. And if you're ever asked on a test, I don't think my test, by the way, but maybe, and they say the biggest worry side effect is Stevens-Johnson syndrome. And this is Dr. Stevens and Dr. Johnson decided on this syndrome where essentially it looks like you've walked through a fire. All of your skin sloughs off and you die of your blood serum leaking out because you have no skin anymore. And it's a horrible death. It's really frightening. And anytime any of my patients even smelled of having a rash, I would send them to the emergency room and stop their Lamictal. And one notable patient had a rash, talked to the doc in the emergency room. He said, it looks to me like a garden variety drug rash. But hey, it is Lamictal. Of course, we should advise you to stop the Lamictal and not have her be on it anymore. And of course, I agreed. It was too bad because I thought it was helping her in her mood disorder. But you don't want to take a chance, right? And things resolved when she was off the med. So indeed, it was a drug reaction. If you take someone off Lamictal, the chances are their Stevens-Johnson syndrome, if it is that, will continue without abatement, even though you've taken them off the med. It's a cascade of symptoms and sloughing of the skin. So very touchy stuff. So go low, go slow, watch for that rash. See if they have rashes with other medications. That kind of helps you because if they do have a rash, you think, oh, it's just a drug reaction, but not the Stevens-Johnson syndrome. So that's the big thing to worry about is the life-threatening Stevens-Johnson syndrome. All right. Schizophrenia, spectrum, and other psychotic disorders. You see how I'm talking about spectrum. You remember I mentioned the surgical nurse who had schizophrenia. I believe that okay, here, let's just take this and run it down. We know statistically that about 1 out of 5 Americans suffer from some diagnosable mental health problem, mental illness problem. Out of those 1 out of 5, it's broken down by people with thought disorders, people with mood disorders, people with anxiety disorders, people with post-traumatic stress disorders, et cetera, depressive disorders. Well, it's my belief that walking around the population in any particular city or rural area, 1% of the population have diagnosable schizophrenia, but it's on a spectrum. There are high-functioning schizophrenics, of which there are many in this world, including that surgical nurse and L. Ron Hubbard, in my opinion, the Scientology inventor, so to speak. And there are many people who walk around with the mindset of paranoia, and that's a paranoid syndrome, right? Paranoid disorder. And if you add to that hallucinations and delusions, etc., you've got the diagnosis of schizophrenia, right? 2 or more of the following symptoms. They don't have negative symptoms so much, although they tend to be a little reclusive. They don't tend to, these high-functioning ones don't tend to have disorganized or catatonic behavior. That's the severe schizophrenic, right? And their speeches can be disorganized or not. So I believe, and this is what outrages me about our cultural trend towards if you have a diagnosis of schizophrenia, 70% of Americans think you ought to be locked away, that there are a lot of high-functioning people with the diagnosis of schizophrenia in our world that are contributing to society, have families or are connected to families. Maybe my surgical nurse was a loner, and I understood why, and it worked for him. Anyway, you wouldn't necessarily treat these people unless they were having problems. My surgical nurse was starting to have problems with his paranoia and voices, and he thought it was going to begin to affect his work. He was such a professional that he caught it early and said, if I can't improve my thinking, I don't think I can continue being a surgical nurse, because I might make a mistake, and that would be, breaking the Hippocratic Oath of do no harm. Very serious guy. Great guy. Who also happened to coincidentally be gay. All right. Made him more of a social outcast. So this is straight out of DSM. You have to have the schizophreniform disorders for less than 6 months. The duration has to be greater than 6 months for schizophrenia. The flattening, the alogia, the avolition, etc. I have a married on divorced in-law living in the Osttirol, the East Tyrol above Italy in Austria. Long story about that, but nevertheless, one of the brothers in this big farm family is diagnosed with schizophrenia. He is treated with a whole holistic psychosocial approach, which even includes sending him off from the farm to a sanitarium for about 2 weeks to a month every year to give his family a break and to give him a new, environment and all like that. He works on the farm in a very limited way, and he's a good guy. I remember when I was younger and talking with him, he would be bothered by me because I had terrible German, and I was, a foreigner, an American, and he would be spooked by me, but he was a sweet guy. And when I basically just sat back and listened or watched or smiled, he was comfortable with me. I remember baling hay with him or moving hay with him, and I was working too fast, and it bothered him and rattled him, and he walked away. And his older brother, the farmer, said, "It's not your fault. It's Lois's problem of social connection." This is through very bad German and English. And it was amazing and he's on low dose antipsychotics, but the wraparound services and the community services and the help for the family is just something that I've just never experienced in the United States. The whole community is there for the disabled individual in places like Austria and many other places around the world. All right, so you have to differentiate between schizoaffective and mood disorders, right? So now let's jump into the medications, which brings us to the first generation atypical antipsychotics, which are the common medications used for schizophrenia and psychotic disorders, and are the common medications used for children and adolescents with thought disorders. Boy, I've got my family history full of it. My mentally ill brother's younger child is turning 17 in next month in December. He has a testable IQ of approximately 50. When he signs his name to a thank you card that his mom completes, it looks like he is a 5-year-old or 6-year-old in his writing of his name. Sweet kid, he remembers you. He's also high on the autism spectrum disorder, and he's also hemophiliac. So when he hits himself when he hears voices and he bangs his head against the wall, it's really quite dangerous because of bleeding. So in the classroom, he always has 1 aide in the classroom and 2 aides in the playground. 1 aide in the playground is to prevent him from hurting himself with his hemophilia, and the other aide in the schoolyard is to help him with his schizophrenia and autism, his repetitive behaviors and his verbalizing hallucinations and paranoia, and also violently lashing out occasionally at others. So he's quite a handful, and yet his parents and the community have done an incredible job with him. He is a product of my brother, my sweet brother, having sex with a homeless, mentally ill woman who he took in for shelter, and she got pregnant, and turns out she had schizophrenia. So he didn't really have a good chance to start with, and he's being groomed at this point, soon to be 18, to go into a 24/7 group home with live-in counselors for the rest of his life. We had hoped he would be able to move to something like a sheltered workshop, or a dishwasher or a stocker in the back of a store, but he's too impaired for that, and his hemophilia prevents it all because of bruising and etc. By the way, his hemophilia medications cost approximately $750,000 a year to the state because of having to come from China, and recombinant porcine, factor VIII, et cetera, that's outrageously expensive and exploited by pharmaceutical companies. That's a whole story in itself. He probably costs the state $1.5 million a year with all his medications and his aides in the classroom, etc. And that's the way it is. I see him once or twice a year, and he's a good kid. Always ask the question, where's the ocean? And after about 2 times, you figure out, oh, that's autistic stuff, and I try to change the subject. All right. First generation, the claim to fame was Risperdal. Now we have a long-acting Risperdal Consta, and many of these medications, such as Zyprexa and Abilify and others, have now long-acting injectables that are good for every 2 to 4 weeks. That's really important, particularly for young adults in their 20s who are going through their second or third breaks of schizophrenia, and that compliance or adherence is an issue, and you really want them to have the medication, so you will go to court and get a court order for forced IM medications, which once they get used to it and it helps stabilize them, they are, in my opinion, so much better and more stable, able to return to a developmental track that they previously were not able to, especially with non-adherence to medication. And so these maintenance IM medications, as rough as that sounds, are really a godsend. You don't want to do that with teenagers, though. You don't want to give them IM injections once every 2 weeks or a month. They're still developing, and it just doesn't feel right. I would not do it for anybody under the age of 18, and they'd have to be like 22 onward, 22 to 28. They're ideal candidates. Some of the newer ones, Invega, Invega Sustenna, the doses are there. Clozapine is quite an amazing medication. Clozaril, Fasiclo are the trade names. I have seen some nearly magical turnarounds with schizophrenia with Clozaril. It can be quite a toxic medication. It can knock out your white blood cell count and have you get, infection and die. So there's a strict protocol with the pharmacy of weekly blood tests to check your complete blood count, specifically your white blood cell count, to look for neutropenia, low white cell count. And the protocol is once a week for the first 3 months, I think it is. And it's been a while since I prescribed it. And then once every 2 weeks for the next 2 or 3 months, then once a month for the next 6 months, and then I think it's once a month for the duration they're taking it, of a blood test to prove, because it's like 1% chance of neutropenia and blowing out their white blood cell count and them dying of infection. So it's pretty serious stuff. When it works, and it works a lot, it's remarkable. I have a very good case example of a fellow I treated at Villa Fairmont, actually, where Harvey was. And this guy came in, he was brilliant. He was heading to law school. He was one of the UC Berkeley undergrads. He'd spent his junior year abroad in China teaching English to Mandarin-speaking Chinese. He was so smart. He spoke fluent Mandarin. And he had a psychotic break in his senior year at Berkeley, racing down the street naked, beating up on people, hallucinating. And he was put on a conservatorship after multiple hospitalizations and refusal for treatment and refusal for meds. And so he came to our institution, and we had him on hold for up to a year. And I was his treating doc. And at first he would do all this gesticulations, is that it, of his mouth. And he would be whispering to himself. And I would reflect it back to him. You appear to be whispering to yourself. And he said, no, I'm just clearing my throat. He was a very smart guy and a real con artist too. And I forced him on Clozaril because he'd been on almost every other antipsychotic and had been not taking it and refusing IMs. And I forced him to take the Clozaril by court order. And within a month, he turned around. And within 2 months, he was normal. His parents were shocked, and they were totally freaked out when he first came in. They were beside themselves. He had threatened to kill them. If you force me into the hospital, Mom and Dad, I'm going to kill you. That was his standard line. And he had knives, and it was very threatening, and police were involved. And anyway, with a lot of hard work, he turned it around, and he was heading back to law school. And I think I've mentioned him to you guys before when I talked about the ethical and legal issues, because I actually got him the book that was written by the USC professor who has a diagnosis of schizophrenia, Ellen, can't remember her name now. It's a little bit different spelling as you might think. It's not Ellen Cohen. I'm sorry, folks. I can't remember her name. But anyway, this is a woman who is a law professor who, when she becomes psychotic, her psychiatrist puts her in the hospital and manages her medications with her. At times she refuses meds in her paranoid schizophrenia. And she's written books on the subject, and she's been an advocate and great source of support to others with schizophrenia. So you can live with schizophrenia, just treat it, and treat it well. Treat it vigorously, and look for lowering the psychotic symptoms. That's what it's all about. For my nephew, who's turning 17 next month, in his probable schizoaffective disorder, that's probably going to be the end diagnosis besides the autism and the hemophilia, he has been on antipsychotic medication since about the age of 6 or 8 years old. Why at that early age? Because you want to have the mind, the system stabilized so that he can benefit from the social and psychological treatments out there and available. And he has benefited from them. He's a nice lad. He's honest. He's kind. He just happens to have a very disturbed mind. So he has benefited from antipsychotic medication over the years. All right. Question 26. Clozaril, Fasiclo, is available through distribution system that ensures monitoring of white blood cell count and absolute neutrophil count, ANC, according to a schedule. True or false? Well, again, I've already given you the answer. Sorry about that. It's true. And it's quite an amazing medication when it works. And it should not be shied away from for treatment-resistant psychotic disorders. And you're between a rock and a hard place, don't hesitate to try for Clozaril. It is only 1% chance of them developing the neutropenia. Okay. Now let's shift to more conventional. Oh, I'm sorry, I need to go back and because I missed out on the second generation atypicals, which have just come out in the last 10 years or so. Fanapt, Safris, Latuda, and Vraylar is the latest. These are newer, cleaner, less side effect medications in general, although the hard research doesn't bear that out. Experience in prescribing bears it out. And for example, my 17-year-old nephew David has been on, it was just started on Vraylar, and he's been through Fanapt, Safris, Latuda over the past 10 years. They worked for a while, or they had to maximize the doses. I remember he was on Safris 20, and he still had violent episodes. And when he shifted to Latuda, things got a lot better for a while. And now they're considering Vraylar as he heads into early adulthood. So start low with the doses, but go up to adult doses. And in general, they're better tolerated, more compliance, etc. Okay. Vraylar was approved by the FDA in September of 2015, so it's just 4 years old, for bipolar disorder or schizophrenia. It rebalances dopamine and serotonin to improve thinking, mood, and behavior. In September of 17, just 2 years ago, the FDA rejected the pharmaceutical company's request for an indication for the treatment of negative symptoms of schizophrenia, the cognitive blunting, etc. They thought the pharmaceutical company was overreaching, which is pretty common for pharmaceutical companies to try to do, sell more product. Now let's go back to the typical conventional antipsychotics, which started out being used as early as the 1950s. I think the first one was Millaril in the mid-50s and Thorazine like 58. And then Prolixin and Haldol came out in the 60s. L'Occitane and Moban came out in the 70s. I've used a lot of these antipsychotics with a lot of children and adults in the 80s and 90s, and I haven't used pretty much any of it lately except for Haldol, where I think Haldol in combination with Ativan every half hour to an hour alternating is the drug cocktail of choice with a raving maniac in a psych emergency that is tearing off light fixtures and trying to jump out windows and trying to hurt and kill people. You have to use an elephant gun, and the elephant gun is Haldol 5 milligrams IM alternating with Ativan 1 milligram IM every half hour to 1 hour until they're asleep. And it's usually 2 or 3 cycles while they're in 4-point restraints, by the way, in a seclusion room. It really works. You just have to keep at it. You don't give it to them all at once, or you could kill them with coma, etc. And you just keep going after it every half hour until they're calm. And then when they wake up, you prescribe something like Haldol to like 5 milligrams twice a day or 10 milligrams twice a day to help manage their symptoms. And then you figure out if you could switch them over time to an atypical, etc. But emergency safety first. The Haldol Ativan cocktail is the way to go. in my humble experience. Moban and L'Occitane had fewer side effects than Thorazine, certainly. Prolixin decanoate was the first one. They now have Haldol decanoate, of course. And that was the first injectable that was a godsend to resistant patients who really needed it, and you could get a court order for it. They'd take a once-a-month injection of Prolixin dec or decanoate. All right. Let's see. Oops, I missed another slide. Sorry. The Trelafons, Millarils, Navaine, Stelazine. These are all conventional antipsychotics. They're hardly ever used anymore, but just for you to know about them. They were kind of the mid-strength, very helpful medications that I learned in the 80s. I've never used ORAP because of liver toxicity. It was the drug of choice for Tourette's disorder, Pimozide ORAP, but I've never used it. There are other ones that are better. Millaril was the very first to come out in the mid-50s, maybe 1955. And Navaine and Stelazine came out in the 70s. A little better tolerated, fewer side effects. But again, we have all the potential for side effects and problems with the antipsychotics, of which can be quite substantial. For example, you just dry up when you're taking anticholinergic. You're always thirsty. You always have dry mouth. You're always a little cognitive blunted with the antipsychotic medications. Even the atypicals, that's why you want to keep the dose the least amount possible. Because what you're doing is it's an antagonist to the dopamine system, and that's also your thinking system too, right? Creativity, life, color, excitement. So what you're going to do if you overdo it with the antipsychotics is make someone who can stare at the wall and have no thoughts. And I might have mentioned to you that I took a low dose of Millaril, maybe 25 milligrams in medical school, just to see what it was like. And I stared at the wall for 4 hours one afternoon on a weekend. And I was thoughtless. There was no there. And that was the lowest dose of Millaril. And we give much more bigger doses to children and adolescents and adults. So it really is like an elephant gun to the head in terms of calming down a overloaded system with dopamine going wild and causing hallucinations and delusions and paranoia, agitation, out of control behavior. They really work, but they're serious medication. And therefore, cognitive blunting and confusion is typical. So you have to be very careful about tardive dyskinesia, seizures, extrapyramidal reactions, dysphasias, where they can't swallow and they actually die from, you need to do a Heimlich on them because they can't swallow and their food caught in their throat. Cardiovascular, blood pressure can plummet, arrhythmia, syncope, tachycardia. My brother Bob, who suicided on a month's worth of Zyprexa, the atypical antipsychotic. And in the autopsy, they said his probable direct cause of death was heart block, due to that he apparently just picked up his month's supply of Zyprexa, got into a fight with his girlfriend, and it was in a depressive episode, and it's a toxic combination of having his meds right there. He'd never been suicidal, shocked the hell out of all of us. We didn't even know he had died for a week until a neighbor asked for a welfare check because his kitty was crying from not being fed. It's very terrible. GI weight gain and sexual decreased libido. Boy, if you want to, and frankly, they use this in the olden days to dampen down kids' libidos in a kind of calm down kid way, which I think was a bit much overuse. Here's an interesting little tidbit. Non-Caucasian adolescent males, adolescent boys, are particularly prone to EPS, dystonic reactions, including torticollis and NMS. Oh my God, Tom. NMS, malignant syndrome. Sorry, it's late in the day. Neuroleptic malignant syndrome, thank you. So if you treat an Asian kid, a Filipino kid, an African-American kid, a Hispanic kid with antipsychotic medications, they are more prone to extrapyramidal side effects. Why is that? I don't know. Is it racist? I don't think so. It's experience. So be very careful about it, is the punchline. Okay. So what is anti-Parkinsonian medication? This is to relieve the neurological side effects caused by antipsychotic medication. The extrapyramidal side effects, the cognitive blunting, etc. So Cogentin and Benadryl are the two biggest ones, anticholinergics and antihistamines. You can also use the benzos such as Valium or Ativan or Klonopin. You can also use beta blockers. Their tremor that they can get with antipsychotics can be dampened down with Inderal or a beta blocker. You can also use dopamine agonists such as Semetril or amantadine. So it's not infrequent, especially with the older antipsychotics, to require anti-Parkinsonian medication. However, now the drug companies say that the atypical antipsychotics are something like 1/10 the risk of the older antipsychotics. I don't think that's true in my experience. I think it's maybe 1/2, 3/4 improvement. Certainly more than 1/4 improvement, but not 10 to 1. That's overstating it. So how do they work? What do they do? They block the excitatory cholinergic pathways in the basal ganglia. They restore the dopamine acetylcholine balance, and they have muscarinic receptor selectivity activation. Now, side effects themselves for anti-Parkinsonian, think of Benadryl, think of propranolol, dry mouth, blurred vision, constipation, urinary retention, stimulation, confusion, delirium, psychosis. So I heard once of a woman who was addicted to Cogentin because it stimulated her, it put her into a semi-delirium and semi-psychotic state that she was compelled to be in. And she would go into emergency rooms saying that she was having dystonic reactions from antipsychotics in order to get a shot of Cogentin. And then she'd be flying high in a delirium. And the pattern got established over 3 or 4 visits to the ER. Hey, wait a sec, she seems to be drug seeking with Cogentin? I've never heard of that before. That was at San Francisco General Hospital, the new Zuckerberg UCSF. Okay, we're going to tap into anxiety disorders, and here is the diagnosis. DSM-5 calls it generalized anxiety disorder, and this was also in the DSM-4 TR, but in the DSM-4 revised, it was over-anxious disorder of childhood, but they threw it back into the adult category of generalized anxiety disorder for the past 2 DSM editions. So picture the child or adolescent who has excessive worry and anxiety. They can't control the worry. They're restless, they're fatigued, they have trouble concentrating, they're irritable, muscle tension, sleep problems, impairment in all these different ways. Imagine, if you could, if you haven't personally experienced it or been around somebody who's been and has an anxiety disorder, what it must be like to be overamped all the time, to just be a worrywart, to be always overthinking everything. What if this could happen? What if that could happen? Catastrophizing, etc. Well, there's a clue. Cognitive behavior therapy can work quite well with anxiety disorders to attack the things like catastrophizing and your formulaic thinking of anxiety will take you. It's like Calgon, take me away. Anxiety disorder, take me into the stratosphere with anxiety. The more you worry, the more you worry. And so the trick is to shift gears and shift the mindset. Very hard to do with anxiety disorders, and medications could be helpful. There's also social anxiety disorder, social phobia, fear of social situations. We used to not give much credence to this diagnosis, but it's real. It's just a variant of anxiety disorders. And the fear or anxiety is out of proportion. Panic disorder, the most extreme anxiety disorder. People think they're going crazy. They go into emergency rooms and they say, I'm having a heart attack. I'm having palpitations. It's happened to a number of people I know. And they get an EKG and they're told, you're having an anxiety attack. Take this Ativan and chill, or this Valium. And within 10 minutes, 15 minutes, it's like, oh my God, I was driving myself crazy. Can be with or without agoraphobia. Oh dear, 2 sensitive fingers. Then there's post-traumatic stress disorder, another type of anxiety disorder. And I mentioned the post-surgery stress disorder. So exposure to actual or threatened death, serious injury, sexual violence, intrusive symptoms, memories, dreams, triggers, crying jags, avoidance, increased arousal. You're just spooked all the time. There's a very interesting show on Netflix called Diagnosis. And one of the male adults had the most obscure diagnosis. It turned out to be PTSD from the war in Iraq. He was a soldier in Iraq, and he saw all his buddies get blown up in these vehicles with the IEDs and stuff like that. And he was traumatized, and he almost looked demented. His negative alterations in cognitions and moods it was almost like he was dementing in his 40s. And they traced it back to the Iraq War and PTSD. That show, Diagnosis, also has a very cool episode on a young woman, a teenager with ruminative disorder. And so, Joy, you might find this interesting about your eating disorder patients. She actually refused to accept the diagnosis of ruminative disorder. She would be upchucking constantly and throwing up into a napkin while she was eating and at the dinner table, and it was a compulsion, a ruminative disorder. And actually, some good work has been done around diaphragmatic breathing and other behavioral techniques to get control of it. I found it very interesting and unusual. All right, folks, let's take a break, our final break of the day, before we jump into the medications used for anxiety-related and stress-related disorders. We'll get back again at 3 minutes after the top of the hour. Thank you.
Okay. Dr. I'm also running the attendance poll.
Excellent. Aiden, go for it. Go for our final hour of Saturday.
You hear you, Doctor.
Great. Okay, thanks.
I think we're always ready for our final hour.
Touche. Okay. Aiden, can you pull off that polling sheet, or do I do that? The "Are you here" question?
The poll is.
Oh, it's still ongoing?
No, it's off. I have turned it
Oh,
off.
how do I get rid of it on my computer? It's covering my slide.
That's it. Okay, let me just. You can just one time put.
Oh,
Alt.
here it is.
Awesome. Awesome.
Yeah, okay, I found the X. Never
Cool.
mind, thank you.
Awesome.
Okay, okay. Took me a while. Those of you who know me a little bit know that I can be techno-challenged, and I have a kind of bad attitude about computers. I start getting nervous instead of, I can figure this out, which is not the way to go with computer glitches. All right. I hope that I'm going to be able to finish the internalizing disorders by the end of this hour. But if not, never fear. We will pick it up tomorrow morning because we have a little more padding tomorrow. And so in either case, it'll work out. Are there any thoughts from you students regarding what I talked about in the last hour? Reflections, corrections, mood stabilizer medications, medications for psychotic disorders, side effects, anti-Parkinsonian medication before we jump back into anxiety disorders. Okay, hearing nothing, we'll go forward. All right, we are on slide 106. So just a quick reflection for those of you who are perhaps older. Remember when PTSD was first talked about after Vietnam, and people thought it was a joke, or people thought it was faking it, or malingering, or something else, or bad behavior on the part of military people. Well, now it's quite legitimate and even recognized in this newer disorder, post-surgery stress disorder. And so there are other, I actually think that we're going to come up with, it'll probably be a joke, but we're going to come up with post-impeachment stress disorder and post-political stress disorder, because if you talk around among your friends and colleagues and people on the street, this business going on in politics right now is quite rattling, quite traumatizing. Whatever position you feel, whatever blue or red or purple you are, it's quite stressful. And it's making people quite on the edge and polarizing and irritable and increased arousal. And I found myself the other day yelling at the TV like an old fart man. You know, it's like, get real. You know, this is happening. Anyway, I digress. I think there are many stress-related disorders out there that we are yet to kind of capture and identify. So, you've done your best cognitive behavioral therapy with a patient with panic disorder, social anxiety disorder, etc. CBT, research shows, is really more effective and sustainable than medication for anxiety disorders. And we'll get into it, of the benzos for anxiety disorders, but there's a real seduction towards quick fix, chill with a pill. And cognitive behavior therapy and exploring things such as catastrophizing and everything is black and white and there's no nuance, and letting yourself go down that path of panic when you could stop yourself in the early stages and distract yourself, etc. They're hard work, but they're sustainable work that stays with you for life, and it's really worth it. However, SSRIs do work. One of my very first panic disorder patient I treated with Paxil. It's my favorite for among the SSRIs because it tends to be more effective for anxiety symptoms over depressive symptoms. And I had a woman in her 30s who was a administrative assistant living in Oakland, I think, and going across the Bay Bridge every day to her work in downtown San Francisco, the financial district. And she started to have panic attacks on the Bay Bridge. And she had to get out of the Transbay Terminal when it was still the old Transbay Terminal and get a bus going back home because she was just in a panic state. She couldn't go to work. She called me up after her first dose of Paxil and said, I just have to give you this feedback, doc. It cured me. A 10 milligram dose of Paxil cured me. I was able to get on the bus this morning and go to work and do my work. And I wasn't all that happy. I wasn't, anxiety free, but that panic just went away and I can't thank you enough. And can I send you flowers and, and all this stuff. And I was kind of amazed myself. One dose of Paxil at a low dose, 10 milligrams, but there it was. I think we increased her dose to 20 milligrams. She continued for another 6 months to a year while I did a lot of CBT work with her. I think I saw her every 2 weeks during this time, and I taught her all these self-relaxation techniques and other cognitive behavioral focus techniques. And she said at some point, I'm ready to try getting off it. She went down to 10 milligrams. She was doing okay. And she was off and running after that without the need for Paxil. It was quite an amazing story for both of us that I remember well to this day. Any of the SSRIs will help with anxiety as well as depression in varying degrees. Paxil being my drug of choice for the higher anxiety and even heading into OCD, obsessive compulsive, the highest, if you will, anxiety disorder. What else to say? Let's move on. Dual action antidepressants. If an SSRI by itself is not enough, if the serotonin system is not enough, then head into the noradrenaline system. It sounds a little contrary to logic because why would you jack up the norepinephrine system with panic disorder? And I can't really explain it from a molecular or a neurotransmitter point of view. All I can tell you is it tends to work. Remeron is taken at bedtime often, helps them get a good night's sleep and be less anxious and depressed the next day. That's its claim to fame. And we know about Effexor and Cymbalta and Prestige and their dosages, Fetsima. Now, frankly, I haven't used these dual action ones on children or adolescents. I've been able to get away with SSRIs for them. You could also consider a atypical antipsychotic in very low dose, like a 0.5 milligram of Risperdal, something like that. Or you could use Buspar, which is a non-habit forming, non-addictive anti-anxiety medication that has touted as a replacement for the benzos. I find it doesn't work as well as the benzos, not as fast, it's not as robust, but it works. And I can't remember who it is now, but a friend of mine told me within the past month, I think it's a relative, up in the Sierras, said he's on Buspar and he found it helpful. And I was kind of surprised that his doc put him on Buspar. I thought it was kind of lightweight and he has pretty serious anxiety. But it worked for him, so I said, great, it's working, super. Continue, won't get off it. He's a guy who's gone through a lot of troubles over his life. All right, Now let's shift to the benzos, because the benzos were always the drugs of choice for anxiety symptoms, right? And there's this whole, not mythology, but story about the LOL syndrome, the little old lady syndrome from the 60s. Think of Valley of the Dolls. Think of women who, before women's lib, and these frustrated, these are all stereotypes. You'll let me apologize up front for these stereotypes with a grain of truth, but these were the bored and anxious housewives with their husbands going off to their insurance company work or their auto sales work or whatever. And the mom was at home, the happy homemaker, except she wasn't happy. She was frustrated and she was bored and she was, put down. Think of the amazing Miss Maisel on Netflix, I think it is, which is a wonderful series taking place in the late 50s. Great acting and very entertaining. Where women couldn't wear pants. They were instructed. I remember my father getting angry with my mother for wearing pants, that wasn't ladylike. And I can't believe she put up with it for as long as she did before she shifted to pants later than other women. And anyway, benzos were mother's little helper back then. The primary care docs, your family doc, your Marcus Welby, gave you a little prescription for Valium or Librium. Librium was the first one that came out in the 50s, Valium in the late 50s. And then later, Ativan and Klonopin and Xanax, that's a famous one. Gets people in trouble. Everything gets people in trouble. And so these housewives were prescribed benzos, and it calmed them down. They weren't as uppity. They didn't want to wear pants as frequently. And it was great. Well, 20 years, 30 years later, they're still on their benzos, just like mother's little helper. And well-meaning docs are starting to pull off the benzos from these women who are now in their 70s and maybe 80s, and they're going psychotic. What the hell is going on here? Well, long-term use of benzos with the dependency that develops over time and tolerance, and then you withdraw it. It's one of the few medications that you can withdraw, and they can go into a seizure, status epilepticus, and die. So the docs quickly said, ooh, got to put them back on their benzo. Well, yes and no. Put them back on their benzo and then wean them off them slowly is the way to do it. I can't remember if we talked about this, so I have to mention it again, and I apologize for redundancy if I did say it, but it's so important. Don't use the so-called American method of getting people off benzos of 10% decrease a day for 10 days. They'll end up psychotic. They'll end up in withdrawal. They'll end up with seizure. They could die. That's cruel. You could do it like the British method, which is kinder and gentler, of 10% decrease a week for 10 weeks, taking almost 2.5, 3 months. But even that, for long-term users and high users, my patient with Xanax, that an older man in his 70s was he early 80s at that point, who had been taking 8 to 10 milligrams of Xanax for 15 years as a way to get off heroin, that he got on after World War II, after being shot up in a plane on the Pacific and coming back with broken bones and on morphine, addicted to opiates with morphine, shifted to heroin. Then he started and ran a successful business in San Francisco for decades as a heroin addict, getting his drugs off the street in the Mission District. And he said to hell with that in his 60s and went on Xanax to get off heroin. Well, it worked, but then he was hooked on Xanax, high doses, 8 to 10 milligrams a day. And it took him 18 months to get off Xanax. I didn't want it to be that long. He didn't want it to be that long, but every time we went faster, he would start crumping and going into benzo withdrawal, very agitated, anxious, couldn't sleep, pacing, and for a guy in his late 70s, I think it was 78 or something, it was miserable. So I'd say, we can't go that fast. We have to go. And he saw me like every 2 weeks during that 18 months. And I used my best cognitive behavioral techniques with him, which he used and did. He was a real trooper. But it took 18 months before he was fully off them and comfortably off benzos. So it's a wicked, wicked thing to do. And it's not a good thing to do for children and adolescents. It makes particularly children and adolescents will get disinhibited, punch drunk. They'll run into the walls in a happy-go-lucky, ho-ho-ho way, kind of stupid, goofy way, because they're punch drunk on benzos. Doesn't happen to every teenager, but it does happen more frequently than you would like. Now, it's really important that you might want to use benzos for a couple of weeks in severe disorders to gain quick control of symptoms. But again, high risk of dependency, don't leave them on it too long, wean them off it, caution them about the risks of dependency. It's also used in alcohol detox withdrawal quite effectively. Whether it's Valium or Librium, there are whole protocols for Librium detox of an alcoholic. It's dual protection. It protects the brain. It protects the alcohol withdrawal person from a withdrawal seizure and possible death. And it keeps them calm relatively through that awful process of withdrawal. And the wickedest thing about that withdrawal is all you have to do is take a benzo and you're out of it. All you have to do is take a shot of alcohol or smoke a cigarette and you're out of that withdrawal. So compelling. And yet you're back to square one when you do it. Okay. Very helpful, but cautiously used. And certainly not for 20 to 30 years on a long-term basis. Use Buspar, use an SSRI if you can't make it through only CBT. Benzo side effects: sedation, drowsiness, dizziness, weakness, unsteady gait, memory impairment, transient memory impairment, etc., nausea, PTSD. So, question 27. Why are benzos not generally prescribed for children and adolescents? Is it because they're ineffective? Are they disinhibiting? Are they overly sedating? Is it dependency? Or is it B and D, disinhibiting and dependency? Tick tock, tick tock, tick tock. The answer is B and D. It's disinhibiting, and you don't want to set up a kid for dependency, especially at that early age in life. All right? Disinhibiting is really what you're worried about with a kid and the benzo. All right. Let's look at even more severe anxiety disorders that border on psychosis, if you will, or it's so crazy that you got to be nuts or out of touch with reality to be stuck in obsessive compulsive rituals, etc. Again, cognitive behavior therapy can be quite helpful and interrupting that cascade of anxiety and panic and forced obsessive and compulsive rituals. And I've had many a patient with OCD and a spectrum of OCD. One guy toward the end of our treatment for depression, sweet guy, he said, "Have you ever noticed, Doc, why I sniff so much and put my finger to under my nose?" And I said, "I thought you had allergies." He said, "No, it's an obsessive compulsive ritual that I've done my whole life, and I'm really sick of it." And I said, "Oh, well, let's take it on." And he got better with it. And he trusted me enough to reveal that this little ritual he'd been doing, which looked so normal, everybody has allergies, right? Or hay fever or something, but he had turned it into an OC ritual. Okay. Clomipramine is the drug of choice, anafranil. It's a powerful antidepressant from the tofranil family. It's an added-on chloride molecule, if I'm right, to an imipramine molecule, making for a kind of dirty, old-fashioned tetracyclic antidepressant with high side effects that is amazingly effective for OCD and worth all the trouble. And I've seen some significant turnarounds, particularly with adolescents with clomipramine for OCD, more than the SSRIs, which are now the standard treatment, but they don't work for severe OCD. They work for mild OCD, sort of on the spectrum of as an anxiety disorder, with Paxil being one of the best, right? And then you can use, and you tend to have to use a higher dose, up to 80 milligrams of Prozac. These doses are higher. Paxil, not 20 milligrams, but 40 milligrams. Zoloft, not 150 a day, but 300 a day. You have to really jack up the SSRI dose to get the beneficial effect for OCD. So that's the take-home message with that. And then it may become so debilitating and so obsessive, so compulsive that it borders on psychosis, that it appears like you got to be crazy to be thinking this way and acting this way, that you can't stop these rituals. So it would be logical to consider an atypical antipsychotic to add to maybe an SSRI or to add to clomipramine. Did you know that Zoloft has been FDA approved for OCD for children ages 6 to 18? That's quite remarkable. Same for Luvox, fluvoxamine. And FDA approval for Prozac for OCD, for major depression also for children between the ages of 7 and 17. The FDA has recognized that the SSRIs are effective for the most part for anything but the most severe OCD, where you would head to clomipramine or perhaps add an atypical antipsychotic. Okay, so question 28. When might a dual action antidepressant be used instead of an SSRI? Is it for panic disorder? Is it after a failed trial of an SSRI? Is it with prominent symptoms of isolation and withdrawal where you might want to have a noradrenergic push? Or is it for OCD? Tick tock, what do you think? The answer is B and C. You might want to consider a dual action antidepressant instead of an SSRI after a failed trial of an SSRI, and for prominent symptoms of isolation and withdrawal, where you want to get them out of their isolation and get, proverbially get them out of their wheelchair and moving. All right, eating disorders. This is for Joy and others. SSRIs, what are you treating here with SSRIs? You're not treating the eating disorder per se. You're treating the affective disturbance. You're treating the dysphoria, the dysthymia that goes along with eating disorder, the hopelessness, the helplessness, the discouragement that I'll never get better. These folks get depressed, whether they're clinically depressed or whether they're dysphoric or dysthymic or they have major depression. It doesn't matter. If you're using your best therapeutic non-drug techniques to treat their anorexia nervosa or their bulimia, and it's not working enough, and they remain too dysphoric, too anxious, too distracted, too hopeless, consider an SSRI. It will raise their mood, lower their anxiety, and they can concentrate on their eating disorder symptoms and make progress. And that's fabulous. So, if you were ever asked a question, do our SSRIs, do they treat eating disorders? Well, that's a hard one because they do help some people with eating disorders, but they don't cure or treat the eating disorder. They just help the mind and the system be more available to the therapeutic and milieu work at hand to work on the eating disorder. I hope that makes sense. And just so, if that's not enough, you then head to dual action antidepressants with eating disorders. Maybe they need to be juiced up a bit. Maybe they're too lethargic and they need a bit more activation. So try Remeron, try Effexor, try Cymbalta, try some of these newer ones, Prestique and Fetsima. And consider atypical antipsychotics in very low doses. And what am I talking about here? Well, if you starve yourself, you got to be crazy, right? I'm joking, but you know, think of thought distortion. Think of reality distortion. Think of, I can push these peas around on my plate for the next hour, and that'll satisfy my counselor that I'm eating as I regurgitate into the napkin or a Kleenex and put it in my pocket to throw away later. And that's a little nutty. That's a little psychotic. That's a little wacko. So maybe you would consider an atypical antipsychotic at a very low dose that would calm them down, be a little bit of ego glue, thicken their psychological skin, if you will, and allow them to progress more quickly and more effectively in their primary eating disorder treatment. Same for mood stabilizers. Perhaps they're kind of on the flighty side of highs and lows, and my God, you're like climbing off the ceiling, and my God, are you ever going to get off that couch and get to work? It appears like a mood disorder. It's not, or you can't diagnose it formally. They have an eating disorder with these kind of manifestations of it, of mood instability, etc. You might want to consider adding a mood stabilizer to it and help them get back on their tracks, so to speak. I hope I'm preaching to the choir here a little bit. Okay, question 29. The reason SSRIs are frequently prescribed for adolescents with serious eating disorder symptoms is that this family of medications, A, tend to lessen both obsessive ruminations and compulsive weight-lowering behaviors. B, they tend to brighten the affect, resulting in greater hopefulness and an effort at maintaining or increasing weight. C, they thicken psychological skin, thereby, see, I give you all the answers up front. It's all of the above, folks. All of the above. Let me just say a word about B, brighten affect, resulting in greater hopefulness and effort. Can't remember if I told you, this is my problem with teaching two courses, is that I steal stuff from one and present it with the other because I like it so much. But this was a real case of a woman whose husband had committed suicide a year earlier, and she had a 10-year-old and a 12-year-old. 12-year-old was a girl, and she said, I have to get out of my shell after this suicide, and my daughter's turning 12, and I promised her a birthday party, and it was like my first social event of a year after her husband died. And she said, I'm a wreck. There's no way I can do this without the help of medication. And I put her on Prozac. I think she was my very first Prozac patient, SSRI, back in like 1988. And she came back and she said, a really successful party, 12 girls, 12 parents, and I pulled it off. And everyone said, it was a great success, and I'm very pleased. And I said, so what's the beef? And she said, I was like a Stepford wife through it. It was like I was acting. It was like I was faking my way through it. Fake it till you make it. And I said, so? She said, well, I don't want to feel that way. I'm very happy I pulled off this party. But she said, I'm left with this feeling of being an actor in my own body and in my own life. And I said, okay, well, how about faking it till you make it? That's an old AA term, right? And pretending like you're not anxious and depressed and you're not asocial and all that, and start behaving or acting, faking it as though you're more with it and more social than the rest. And before long, she was able to come back and say to me, it's working out just the way you said. It feels more authentic and more real. And by the way, now that I'm beyond my husband's suicide and have these successes under my belt, so to speak, how about let's get me off Prozac and see how I am? And I weaned her off Prozac after, I think, about a month of lowering the dose. And she said, you know what? I'm a little more anxious, I'm a little more depressed, but I got my mind and I'm not having these word finding problems and it's on the tip of my tongue and I don't feel inauthentic and I don't feel like a Stepford wife, and this is great. This is actually me before my husband, decided to commit suicide. So that's a story for you. All right. What else we got? Okay, so now we're going to do a brief one because it's the same slide. I just changed the title of psychotropics for somatic symptom and related disorders. It's the SSRIs. So, we have some cultures around, even including our own, that you have vague GI symptoms without medical explanation, such as butterflies in the stomach, vomiting before, there are a lot of artists and performers who say they routinely throw up in anxiety before they go on stage, and then it's acting. And I have to tell you, folks, after 20 years of teaching this course, there's a bit of acting in me to pull this off. You sort of go into the zone when you give a lecture or a performance. I went to a speech coach, and that's one of the things she taught me was to act, to fake it, to act like you're an enthusiastic, excited presenter. And I recently, maybe about 4 years ago, I presented at a conference, at an addiction conference in La Quinta, California, Coachella Valley, and the topic was treating the dual diagnosis client or patient, those with addictive disorders and mental disorders. And it was standing room only. There was room for 100, maybe 150 people in the room, and there were 200 people in the room with everybody lining the hall, lining the walls and the back and everything. And I was a performer. And a couple of friends who were in the front row watching me said, you're a different person. You entertained, people were laughing. You were watching the audience and reading them. And it's because of speech coaching, where the speech coach said, the audience is constantly saying to you, Tom, why do I care what you're saying? And why should I listen to you? Teach me something, excite me, make it worth my while that I got off my butt and came to your course. And that's what I did. I acted, I faked it, but God, the reviews were great, and I was very proud of myself. I got across some great clinical information because in the mental health world, people don't know enough about addiction, and in addiction treatment world, people don't know enough about mental health issues, and the overlap is about 80%. It behooves you to learn the other side of it because those are the patients and clients we're dealing with, and it's acting. And SSRIs can help you be a better actor. Can feel phony and inauthentic and all that, but hey, there you go. So rumination disorder, I mentioned the Netflix series Diagnosis. I found that fascinating. the treatment is behavior modification, habit reversal training, and diaphragmatic breathing exercises. But SSRIs can take the edge off and help you be a better actor for a while till you get it down. Same thing, here we are, repetitive. This is why this part of the talk is easier, because it's repetitive. What do we go to next? If the SSRIs aren't enough, you go to the dual action antidepressants. You go to the low dose atypical antipsychotics. I'm going to repeat this for a couple times over with other things. Benzos. Okay, now benzos for somatic symptom and relating disorders. So benzos can be enormously helpful in a short-term way to reduce the anxiety and panic over somatic symptoms, such as functional recurrent abdominal pain, RAP, where there's no underlying organic cause, but the treatment is behavior therapy and anti-anxiety medication. You stop carbonated beverages, you stop chewing gum, you stop them from swallowing air. Use a benzo for short-term relief. Don't get them hooked. Question 30. Selective serotonin reuptake inhibitors are used with children and adolescents to treat depressive disorder, anxiety disorder, obsessive compulsive disorder, eating disorder. I hope after listening to this afternoon's talk, you're going to say all of the above. Higher doses of SSRIs are generally required for the higher anxiety disorders. So that wouldn't be depressive disorder. That wouldn't, well, it could be psychosomatic disorders, but they don't feel the anxiety as much as they manifest as psychosomatic symptoms. It's gonna be E, B and D, which is anxiety disorders and obsessive compulsive disorders. And the more the panic, use the stronger anti-anxiety SSRIs such as Paxil, paroxetine. Okay, ladies and gentlemen, oh my God, we have caught up and then some. So let's quit in 5 or 10 minutes, but let me listen to you. And I'm just going to leave the open mic open. If there's nothing for 5 minutes, we'll have a nice meditative session. If you want to respond with a case of yours or a challenge or it didn't work out or what you learned, this is the time. I'd love to hear it.
This is Rebecca Coleman. I just want to thank you. I thoroughly enjoyed today's lecture and your stories and your humor. So thank you.
Is it going to be useful to you in Bedford?
I'm going to try to use it. You know, I might not be as humorous as you.
You remind me of a kind of a weird philosophy I've developed in life that I'll share with you, and that is, it's kind of narcissistic, but here it goes. It's my job to educate people around me on how to behave toward other people and toward me. It's a high burden that I take on, and it's caused me some grief at times in my life. But with respect to Bedford, Pennsylvania, it's your job, Rebecca, in a way, to educate your colleagues in the community on how to do a better job with their clients and patients, and also treat you better in the process.
Thank you.
You do it with respect, you do it with humor, you do it with collegiality. Who do you pick at in your life? Who does one pick at in their life? You pick at your friends and your loved ones because you know that they're going to tolerate it and not kick you out of the door. And so a friend of mine just was at a dinner and said, you know, my other friend, somebody said, you're like two sisters bickering with each other. And they both laughed and said, yeah, we've been good friends for years. That's what, you know, you can bicker with your colleagues, but you do it with humor and you don't do it with meanness and you do it with their best, interest in mind and yours also. I don't know. I don't want to get too out there on it, but any other thoughts?
Dr. Brady, I had a question in regard to eating disorder treatment. I've been hearing more about using naltrexone and Vivitrol to help control cravings for purging and also potentially to limit some of the high that people are getting from starvation. What are
Right.
your thoughts with this?
Yeah, we're going to talk a little bit about naltrexone, Vivitrol, etc. tomorrow in the section on substance abuse disorders, but it's quite valid. When one takes that first drink of alcohol, one of the biggest reactions you get is a dopamine reaction. And that's why that first drink at the cocktail party makes you sound more intelligent and more social and funnier than you really are. And you but that second or third drink kind of puts you into a bit of depression and funk. And so what you're nailing with naltrexone, an opiate antagonist, is you're not getting that dopamine rush from the starvation, from the first drink of alcohol, the smoking of the cigarette, or the taking of the heroin, or the shopping addiction, or something like that. You just don't get that first excitement or buzz when Amazon Prime sends you that thing in the mail. I had a patient who was kind of addicted to online shopping. It would drive her husband crazy because she would get she was a real estate agent, quite successful, and she got 2 or 3 packages daily from mail order places, open it up, look at it, package it up, and return it. And it was driving her husband crazy, like, why are you doing this to me and to us? It's not costing any money. Yeah, but it's like, you're an intelligent person and you're successful. Why do you do this? It's the dopamine rush. And I bet if I had thought about it, we worked it through with couples therapy, actually, and told him to lighten up and mind his own business, and she wasn't causing any harm. And oh, by the way, could you consider lowering the packages to 1 or 2 a day instead of 3 or 4 and see how that feels? And oh, could you then reduce it to maybe none or 1 a week and see how that feels, and go on walks and spend time with your husband instead of shopaholicism? And anyway, we did it in that couples therapy way. This was a couple, by the way, that met at a bar, and they really hated each other from the beginning, although they were sexually attracted to each other. And the criteria that she gave me when she hired me as a couples therapist is every other couples therapist we've seen told us to break up. And I won't work with someone who tells us to break up. I've failed enough, and I'm in my mid-50s. I don't want to die alone. He's kind of a jerk, but he's all I've got, and he's halfway reasonable. And that was the premise of the couples therapy. And 5 years later, it was much torture for me and for them. They were settled into a comfortable marriage. And she wasn't a shopaholic.
That's worth your hallmark right there.
That's right. That's right. So I took her at her face value and said, you want to stay together, and I'm going to bend over backwards, even though I kind of both think you're jerks, even though I didn't say that out loud. And it worked. So I believe in the idea of Vivitrol and naltrexone. I think that Vivitrol has been overhyped a bit because of its marketing and all like that, and it's very expensive. I was even involved with some of the people that were in the initial trials, and I thought it was a really good thing. It was a good addition to the treatment field of addiction. But I think it could be quite useful. I've used it. I'm going to tell you the story tomorrow, but I'll tell it to you now about a 10-year-old inpatient that I had who was probably the lowest intellect kid I've ever worked with. I think he had an IQ of about 20. He'd always been institutionalized, and he was brought into the hospital because he kept biting himself and whacking his arms on the hallways, injuring himself, and it was almost like a compulsive ritual, and he was getting off on it in an addictive dopamine way. So we did two things. We splinted his elbows so he couldn't get at his hands. We used paint stirrers, like short rulers, and made out of wood, and we just taped it over his arms, so he walked around like a bit of Frankenstein for a week or two. We took him off when he was feeding and stuff like that, and we gave him, I think, 50 or 25 milligrams of naltrexone, or was it naloxone, the oral one, in the morning, and that took the edge off his opiate surge when he bit himself. So it really hurt. And it works when the delicate cutters and the biters say ouch instead of, oh, how soothing, how relieving to cut myself. It's like, ouch, I cut myself. That's what naltrexone does for you. And that can be the beginning of a behavioral plan to get them off it. Any other thing for a couple minutes? Going once, going twice. Okay, cool. All right, let's quit. And tomorrow morning at 9 a.m. Pacific time, 12 noon Eastern time, we will plunge into everything else, which includes all the disruptive disorders and why in the heck would you ever treat autism with medication, and God forbid treat a conduct disorder, oppositional defiant kid with medication. And I'm going to give you, hopefully, in Tourette's disorder, hopefully I'm going to give you the nuances to navigate that world. So I look forward to it, and you all have a good afternoon and evening, and I'll see you tomorrow.
Thanks.
Okay.
See you, Doctor.
All right. So Aiden, I'm going to sign off.
Absolutely, Doctor. I might just shortly reach out to you over the
Sure.
phone.
Give me a call.
Sure.
Okay.